Okay, I'm just, the live is on. Yeah, I'm just double checking that it's going, and then I'm just putting a little tweet with it. And if you guys want to go to your Twitters and reshare the live stream, you can while I'm getting started up here.
Yep.
It always grabs an unflattering screenshot of me at a starting point, but that's okay. That's how it goes sometimes. Okay. Oh, wow. We already have 22 viewers. That's pretty good.
All right.
Hello, and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA RAPP. I'm your host today, Raj Gupta, and I'm coming to you from Nashville, Tennessee. Great to join everybody here today. It's been a while since we get on these live streams and get out to talking to you, but I always look forward to it. We are going to be discussing an article today, came out in Anesthesiology back in not that long ago, just last month. And we'll get to that in just a moment. Before I get started, I want to remind you about a couple of things. First off is ASRA is doing a joint conference, an online virtual conference combined with ASRA, the European Society of Regional Anesthesia. And it's going to be next month in September. And, you know, here's the best part about this conference. If you're a member of either society, it's completely free. 24 hours nonstop, 24 hours of content, combined effort of educators from Europe, from the Americas, all over the world. We're going to have an amazing group of people that are participating in this conference. And the topics are going to be acute and chronic pain and regional anesthesia. So lots of wonderful material for you guys to dig into. All of that's going to be enduring material as well. And that's something that you're going to be able to watch afterwards. But to get the full value, you want to watch it live because you can actually interact with the speakers, ask questions, interact with the community who's watching on social media. So I think it's a fantastic way to stay in touch with this community, especially since all of us are longing for more connection with each other as we're social distancing in each of our respective countries. So go to the website for ASRA Society or for ASRA.com or for the European Society and find the registration for the September conference. And please join us. I think it's going to be a great meeting and I think everybody will enjoy it. From ASRA's perspective, they have made the decision that we're going to do the fall meeting as a virtual meeting as well, the official fall meeting. That's going to be, all the details are going to come out in the very near future, including when to submit abstracts. But again, go to ASRA.com to find all that information. ASRA is also going to be doing a lot of webinars in the near future. They're already starting some of them. We've been kind of experimenting to see how effective they are. Have had very good engagement and enrollment in some of these webinars. So again, go back to ASRA.com, click on all the links that are appropriate, find out what's happening with the society, become a member if you aren't already, and then check your emails because the emails will also have updated information about all these events. So I just want to remind you that even though we're all longing to be together, even though we wish we could be at conferences together, having a cup of coffee or a drink in the evening, we still can stay connected with the content. We can still stay connected with the people. There's lots of new and innovative ways we're going to do that. And actually, I think this makes this more accessible to a wider audience than we've ever had before. So maybe we'll learn something new in this process. So without further ado, I want to make sure we get to our panel today. We have with us, let me get everybody on here. So we've got Gary Schwartz from New York. Gary, how are you?
I'm doing great. Thanks for having me again, Raj. Always a pleasure.
Yeah, good to have you. And Ketan Chopra. Ketan, have you moved yet, or are you still in Ann Arbor, or where are you now?
No, I'm in sort of the downtown Detroit area, but my practice kind of has me going to a few different places. So nope, staying here for now.
Still in Michigan.
Yeah, absolutely.
And our guest today to talk about this topic, Sam Naruz. Sam, how are you?
I'm good. Thanks for having me again.
Where are you hanging out these days? You look very comfortable there in your lounge chair.
I'm at home. I'm home someday.
They let you go back to work though?
I'm working. Yeah, we started back after the Labor weekend. So
Yeah, so it's been busy again. Are you guys at full capacity?
almost.
Almost.
I would
Yeah.
say 75, maybe 75% capacity.
Yeah. Well, Hari wants to say hi to everybody, so I popped him up here on the screen. Hi, Hari. Thanks for watching. Always good to have you. We got to get you on here as a guest here pretty soon, too. Okay, so let me bring up our topic before we get any further. So on the screen, you'll see this is the publication in anesthesiology. It's entitled Ketamine and Magnesium. Hang on, let me take this thing off so you can read it. Okay. Ketamine and magnesium for refractory neuropathic pain, a randomized double-blind crossover trial. This is out of France, where they actually did this randomized trial, and they are looking at addressing or partly addressing this question of whether ketamine, IV magnesium are actually useful in the management of neuropathic chronic pain. So before we get into the details of the article, Ketan, I don't know if you want to start with this. Tell me a little bit about your impressions. You're coming straight out of training. Tell me a little bit about your impressions of ketamine and magnesium in the treatment of chronic pain, and then we'll dive into the study and see where we go from that.
Yeah, absolutely. So, at the University of Michigan, we often, use ketamine as a post-operative type of pain management modality. Often we'd have patients who are, opioid tolerant or who the PCA just wasn't cutting it for, and we would give them, 1 to 3 days of ketamine post-operatively to sort of wean down some of their PCA requirements. And that's the experience that I had with it in terms of training. In the chronic pain setting, I think University of Michigan is still sort of developing that infrastructure. I think with a medication like ketamine, that, as we learned from the study, does not have a lot of real literature about in terms of the dosing, how long you should give it, the type of patients you should use it for. Infrastructure for this type of medication is more important than anything. And I was excited to read this paper because I didn't know a whole lot about using ketamine as a medication for chronic pain outside of the sort of perioperative setting. So that's been sort of my experience with it, and now we're sort of delving into more of the chronic pain aspect of it.
Yeah, and Sam, we use it at our hospital, not so much magnesium, but IV ketamine for that acute pain purpose. And the authors of this article do mention acute pain as a component of its use case and some literature surrounding that. What about chronic pain? What's the conversation occurring in the chronic pain world about these drugs? I mean, from what I'm hearing, there's excitement, there's interest, and hope surrounding these as a cure-all for a few different types of chronic conditions.
As you know, I don't do acute pain service a lot, so my experience mainly with chronic pain. You can say if there is exacerbations of chronic pain, it's an acute pain. I personally use it a lot in my practice, but I use it mainly as an outpatient. I think it has a decent evidence in CRPS. Although it's a rare disease, I won't say this is the majority of my patients, but believe it or not, I use it more for intractable headaches. Migraine headaches, trigeminal neuralgia, post-herpetic neuralgia, especially in the face also. Those are intractable pain disorders that usually don't respond well to more conventional treatment. So you can say it's an acute pain. I mean, trigeminal neuralgia, even migraine, status migrainosus, this is an acute pain syndrome. So I believe, if any, it has more role in acute pain, or what we call episodic pain. And we can, when we dive in the study, I'll tell you why. In any episodic pain, more than just chronic, non-identified pain.
And so when you're talking about using it for these cases, are you giving it one time, or it's a series of treatments? Because you mentioned this is outpatient. So how do you handle that?
Yeah. I mean, the protocol that they said, actually, maybe the initial dose, and then we repeat it. It depends on every patient response. I don't do daily infusions. I know we don't have face-to-face comparison between those protocols, but I share with you the protocol that I use. Daily infusions, I don't use it. I use it once a week for maybe 3-4 times, and usually this is enough to control the flare-up of trigeminal neuralgia, post-herpetic neuralgia, or status migrainosus. Usually they need only 1 or 2 infusion. But definitely, I can't remember I did it only once and that's it. Unless there are side effects or the patient didn't like the experience of the infusion because of the cognitive dysfunction that might happen with ketamine. But even if they failed or they no good response to the first infusion, I would say I would still offer it another time. It's a low-key thing. If there's no side effects, no significant contraindications, I would do it again. But remember, those are intractable neuropathic pain syndromes, whether CRPS or like shingles. Transverse myelitis, I remember I have a patient with transverse myelitis, spinal cord injury, nothing helps. Honestly, it was ketamine that gives decent relief. It's not long-lived, I agree, it's short-term. So for the flare-ups, again, for the episodic flare-ups, I think ketamine has a role.
So Gary, let's talk a little bit about what the connection is between ketamine and magnesium. And this article dives into it a little bit, but help the audience understand kind of why these drugs are talked about in this context of chronic neuropathic pain, where the hope is surrounding them, and how those two are connected.
So the main reason people are looking at magnesium and ketamine, and I agree with what Samer said before, it shouldn't be as a first-line treatment. These ketamine and magnesium infusions, they're for chronic type of episodic pain that's intractable to all our other standard treatments. So ketamine is an NMDA N-methyl D-aspartate receptor antagonist, and it helps with the central sensitization of pain, which is why it's been shown to be useful, even in short term with the trigeminal neuralgia, some sort of cancer pains, these episodic headaches. And magnesium, similarly, but in a little different receptor, is a physiologic blocker of NMDA, the receptor as well. And it's been shown as well to be effective in some sort of neuropathic pain. That's why they looked at this. And also, both of these medications have a long history of safety, efficacy, and also they're cost effective. They're not that expensive. It's not a brand new drug that's costing thousands of dollars through the FDA. We already have them at our disposal. They're easy to give in an infusion, in a controlled setting, and they're safe in that regard as an outpatient or an inpatient.
Ketan, I cut you off a second ago. You wanted to add something?
Oh, I was just going to ask Dr. Nowrouz. He talked about using it 1 time a week. That's sort of how he's been using it. I was just curious to hear his dosing regimen, because in the article they talk about like 0.5 milligrams per kilogram, over 2 hours, and sort of off that. When in anesthesia, we tend to bolus these medications first to, and we're told as trainees it establishes like a therapeutic level within the bloodstream, and then you maintain an infusion. I'm curious, what is your sort of dosing regimen, and is there any thought or any literature in bolusing it initially and then continuing infusion?
There's too many different protocols, and I don't think you can say one protocol is better than the other, because there was really no strong evidence supporting one over the other. But what they used as the first infusion, 0.5 milligram per kilo. And actually I infuse it over 2 hours. Actually, I use exactly this protocol. But beforehand, I always give 1 or 2 milligram of midazolam. Midazolam, actually, it's another NMDA receptor antagonist, but it's more, it blocks some of the side effects or the cognitive symptom that they don't like this experience. And if the patient had a decent relief, I mean by decent relief, generally, I mean, it has to be, everyone is different. I don't go for numbers. It breaks the cycle of the status migrainosus, but for 3 days, the headache came back. Then I asked them to come again for 5 days a week. I'll do the same infusion if they did well. If they did not respond well, I go up to 0.75 milligram per kilo for another 2 hours. My maximum, I used 1 milligram, and this is usual for younger, 1 milligram per kilo. I don't do it more than 3 or 4. And I mean, either it will have maintained relief, or if they don't have relief, then I will stop it. And I think in the recent, if I remember, in the recent recommendation by ASRA and the AAPM that Steve Cohen and the whole group did, if I recall correctly, I remember that we capped it at 10 sessions a year. So you have 2 episodes of those a year, like 3-4 infusions every week for 3-4 times. And then if it happened again in a few months, you can do it. I remember the other most common protocol is you do it for 3 or 4 days in a row. This is fine. I mean, I did it once because the patient was really bad, vomiting, nauseated from status migrainosus. It didn't help at all. So we brought her next day, we do it. So rarely I do it a few days. This is if truly status migrainosus and you could not break the cycle of the headache for the first infusion. But more commonly, for neuropathic pain and less urgent neuropathic pain syndromes, I do it once a week, 2-3 times, sometimes 4. I mean, we're going to talk later about the design of the study and stuff. Actually, it's a very decent study, honestly.
Yeah, let's talk about that a little bit. Let me describe this study design here. Let me see if I can pull it back up. So I'm going to see if I can pull up their. Hang on 1 second. Let me switch to that. So this is what I want. So in this study, what they did is they recruited, their goal was to, based on their power analysis, to have 20 people enrolled, or 18 is actually what they wanted for their power analysis, and they got 20 allocated. And they did this as a crossover study. So they were randomized to receive either placebo, ketamine, or ketamine with magnesium. And what they did is this was separated by roughly 35 days, if I remember right. Yeah. 35 days. And so each time they came in, they were randomized to allocate to one of those treatments. And obviously, if they received it once, then the next time they received one of the other 2, the next time they received the 3rd medication. And then each time they were doing a diary assessment of their pain scores, their peak pain each day, or maximum pain intensity each day. And then when they actually came in for the visits, they would go through a battery of surveys about their mood, about their overall pain experience. And I think they also kept a diary of how much pain medication they were taking as well during this. And they followed these people for different time increments after each treatment, trying to see if they could elucidate a difference in effect based on the treatment that they got each time. Interestingly, I thought it was funny that they also informally asked the people if they knew which drug they got each time. And I think it was like 50-50. They couldn't always tell which medication they got. So that's the core of the study design. Anything you guys want to add to the study design here before we talk about the what they actually saw as outcomes? No. I think that's the basic thing. And these are patients who had neuropathic pain. These are patients who were ketamine naive, so they did not include anybody who had received ketamine as treatments in the past. They also had other exclusion criteria based on their medications or medical history to make sure they didn't have a reaction to the a risk of a reaction to the ketamine or magnesium. The source of neuropathic pain for these patients were either surgery, radiculopathy, trauma, diabetes, chemotherapy. And like I said, they did a power analysis to determine an effect of difference of 35% reduction in pain, and got a sample size of 18, and they enrolled 20 for the study. Half of them male, half of them female. I think that gets to the core of the study population. They had a few people excluded. 2 people didn't meet the inclusion criteria. 1 person from their original sample declined to participate. So that gets us to the results. Ketan, you want to talk a little bit about the results that they found here? I'm going to try to pull up the graph.
Yeah, absolutely. So the primary endpoint was essentially assessing pain intensity between the three groups over a 35-day study period. And in this study that they found that there was no statistically significant difference between the three groups after 35 days. So this includes, the ketamine group. This is the ketamine and magnesium group. They even went so far as to include groups that got ketamine and then ketamine magnesium right after. So even that sort of additive effect that we might think might happen did not in this study. And a few of the other secondary endpoints that they were looking for were, maximum pain intensity at night, pain at 14, 15, 21, and 28 days. There was also no statistically significant difference as well. The one thing that they did find was at 7 days, there was a difference in the ketamine group, I believe, in terms of statistically significant decrease in pain, which sort of speaks back to the concept of using it in the acute pain setting. So that's sort of what I got from the results from this paper. Obviously, the sample size was quite low, but that's essentially a summary of what they found in their study.
Gary, anything to add about the results, or Sam, either of you?
Well, Ketan had a good overview of it. I think the biggest thing that it shows, and someone just chimed in, it just with the result was one, it's varying neuropathic, different conditions that they looked at, but the benefit, I think, as Samer said earlier in his practice, he brings people normally back within a week or two. The 35-day difference is a long time to bring a patient back between infusions. And as it's shown in the past, it seems to work better for episodic or acute issues. So I wish someone studied that. If you follow them up, bringing back more frequent infusions, or if they did not respond, like as most of us do in our practice, if you don't respond to the first dose without side effects, you'll normally give someone a second run with a little bit of a higher dose, which they unfortunately didn't do in this study.
Mm-hmm.
Sam, any thoughts about the results that Ketan presented so far?
Yes, I'd like to make a comment about the sample size. I mean, I had a question here or a comment that sample size was low. They claim that they calculated the sample size depending on a pilot study that they did before, and they looked at the pain, the area under the curve, and they looked at a couple of studies for CRPS. So I think they did their due diligence to come up with a good power for this. My concern is the diversity of the neuropathic pain syndromes that they added. And that's why I want to come out from this session with the concept episodic pain. Episodic pain. They included patient with diabetic neuropathy. I mean, you have a patient with diabetic neuropathy for 20 years. Do you really expect that giving him a ketamine dose will fix him for 5 weeks? I mean, come on, you will take a Nobel Prize for this. No, you need a neuropathic pain with peaks and troughs, flare-ups. You have a history of, again, that's why my perfect examples will be trigeminal neuralgia. It comes and goes. There is remissions, there is relapses. Neuropathic pain after back surgery. I won't do it unless it's a new onset, like a nerve injury kind during surgery, or from prolonged nerve impingement prior to the surgery. They have residual neuropathic pain. So I know that the course should be like 2 or 3 months. They failed conservative treatment. I will offer IV ketamine 2 or 3, 4 sessions, because I know the duration of the illness. But chronic neuropathic pain, like diabetic neuropathy, honestly, I don't see this. And I mean, you did not fix or treat the cause of the pain. You are just giving a pain medication with a short half-life, and you are waiting 5 weeks to see a response. So I think the patient selection group was not the best. That's why our strongest level of evidence, I would say CRPS, and then next to it will be maybe migraine, episodic chronic migraines. So patient selection is something. The follow-up, actually I called another French group there. This group are really good group, by the way. They are very good scientists and clinicians, and apparently in France, they use IV ketamine a lot for chronic neuropathic pain. That's why they were charged to look at it. And they said their next project is doing different protocols for different infusion in 500 plus patients. So we'll have good answers. But following it for 5 weeks, I mean, I'm not surprised that there was no evidence. However, as I said before, when they looked at 7 days, there was statistical significant one difference. And this is what we see clinically. And I'm sure if they looked at 2 or 3 days or 4 days, it will be better. So this is the indication. You put in your mind, you have someone with 3-4 days of headache, you want to abort this headache, you do it. Because what's the other option? They will go to the ER. What they're going to do in the ER? High copay. They're going to give them infusion. They're going to give them 5 tablets of hydrocodone or oxycodone and go home. And they're not going to fix the issue. So I think it has a role in selected patients with knowing that short-lived, weak. Do we have a cumulative effect? This is a whole kind of worms. We can talk about it later. If there is a cumulative effect from repeated or not. They looked at it. They found 12 out of the 20 patients, they got randomized to 2 ketamine infusions in a row. Definitely one was ketamine and the other was ketamine plus magnesium or vice versa. So it's only 12 out of the 20. They were lucky to get those in a row. But again, this 2 in a row means 5 weeks. And they didn't find any difference then if they got placebo in the middle. So ketamine, 5 weeks placebo, 5 weeks ketamine. Didn't find a difference. Definitely, ketamine won't be effective for 5 weeks or even in the blood or the brain in 5 weeks. So I will say they did a decent study studying this specific protocol, whether we agree or not about the protocol. But again, it's randomized, double-blinded, triple crossover. They studied the number to include 0 dropout. This is great, 100% follow-up of the patient. Honestly, you cannot ask for more for this particular protocol. So I think the next study should be repeated injections and we'll have better answers, clinically relevant answers.
One of the questions James Kim puts up here said, regarding episodic pain, would you consider patients with sickle cell crisis good candidates for ketamine infusions during admission? So that's more of an acute pain question, but sort of an episodic pain for some sickle cell patients who have chronic pain conditions and are chronically taking opioids or other pain medications.
Absolutely. There is a theoretical concern about vasoconstriction. I don't think it's really valid. I think controlling the pain will cause more sympathetic surge than ketamine. So blocking the pain will relieve lots of the sympathetic tone. I will say ketamine is a great option, definitely hand in hand with IV hydrations. And I'm aware of few ERs, ER physician, this is part of their protocol for sickle cell crisis.
Hey, Gary, you do acute and chronic pain. Have you run into this situation where you have a sickle cell patient come in with a crisis and you've used things like this, magnesium, ketamine, any of these drugs?
Not magnesium. Ketamine very rarely if they get admitted and they do not respond to conservative treatments. In our current hospital where I'm working now, we don't have a large sickle cell population that comes in through the ER. Our biggest issue in our hospital is that we can only give the ketamine infusions in step down or ICU and the emergency room. So for the few cases we've had to use it, we've kept them in the ER because they did not mandate an ICU or step down admission, which makes it a little bit tricky in my institution. But it did help that patient a lot. And I agree with Samer. I think the vasoconstriction is more theoretical. I think not controlling the pain and not hydrating the patient is the worst situation for these patients, because the faster you hydrate them, the faster you control their pain, the faster they go back to their lives. The more difficult patient is some of these sickle cell patients come in on chronic opiates that get up titrated each admission, and now they have a crisis. So that's some of the most beneficial patients that we've used in the past that have seen results. Mainly
for reduced opioid escalation as an adjunct at that point, huh?
And pain and just pain control. It's very hard if someone's on a few 100 milligrams of OxyContin coming in the ER and now they have a sickle cell crisis, which is a known painful condition. It's really hard to treat that.
Yeah, I've had many of those patients over the years. Our hem-onc service now is actually handling most of that, but I don't think they've gotten to the point of moving towards ketamine. I know they started trying lidocaine actually infusions on those patients. I don't know what success they've had with that, but there was some conversations a couple of years back about including ketamine This was in the process of trying to get ketamine approved for more floor use, which we've made progress on since then. Ketan, at Michigan, I don't remember when I was a resident there taking care of very many sickle cell patients. I don't know if they've had an increase during your fellowship there. Do you remember taking care of sickle cell patients there?
We got a few. It wasn't like a plentiful patient population for the acute pain service, but we did get a few. And then I guess just to sort of be a devil's advocate here, I guess my concern with that was there were times where we would have patients who came to us, including sickle cell patients and a lot of chronic pain patients, and they would come to us and just say, you know, I'm here for ketamine. And oftentimes that would put us in a pretty challenging situation because I'm speaking back to what I said before, infrastructure is so important, right? So I'm talking about acute pain, it's a little off topic, but you know, the way our service worked is we had, you know, an acute pain nurse that was on 24 hours a day, and we're extremely lucky to have that. And not a lot of situations do. And they would manage not only all of, you know, the epidurals and nerve catheters, but also the ketamine patients as well. And a patient who's on ketamine, things can change pretty quickly. You know, if they start having hallucinations, you know, side effects, things like that, they do need people to be able to respond to that pretty quickly, especially if one of the physicians is not nearby or in-house. So sort of get off topic there. Not a lot of sickle cell patients, but selection protocol is very important. You know, we didn't just kind of hand it out because, you know, I'll be honest, there were times where I was on a call, you know, over the week, and I would get a call at 3 a.m. from the nurse saying, hey, this patient's here. They said they want ketamine. And I'm not trying to be a cynic or anything like that, but you just need to have a really strong protocol in place and selection criteria, because otherwise, the thing that Dr. Naru's mentioned that's very eye-opening to me is this is a very episodic thing. It's not a magic bullet. Like, you can't just have chronic pain and you just give someone ketamine and that's how it is. But so I think that's the one thing that was great about U of M was we were very selective with who we gave it to, and I think that's important for any institution or you know, protocol moving forward.
So Claire Lobo from Portugal is saying in her clinical practice, ketamine is one of her silver bullet drugs for difficult cases of pain control, either acute or chronic. So again, reinforcing that episodic nature that we've been talking about over and over. And, you know, it hadn't occurred to me until you just mentioned the people saying, I'm here for ketamine. Sam, have you noticed, you know, we've historically had a problem as we've looked backwards in time with this quote unquote pill mills with opioids when we had oxycodone and OxyContin come online, and you had clinics where people were just saying, yeah, I have some sort of pain, and now you're getting prescriptions. Are we at risk of that with IV ketamine infusions, where we turn into places where people just say they have pain just so they can get the high from ketamine? Although I don't think these doses are quite that impressive for creating that effect.
I don't think it's a problem with IV ketamine infusions because it has to be in an ER setting, IV infusion center. I would be more concerned actually about nasal route of administration of ketamine. But there is always a concern. There is always a concern, and we need to monitor the patient. But for our scope of practice here, because we don't do it for depression, the IV infusion, I think it's a low key because you control it. They come only 1, 3, 4 times, and they won't have access to it. Since we mentioned depression, honestly, I totally get it for depression because I hear it a lot from the patients that it helps. The patient, they know their body much better than anyone else. Yeah. And we always only focus, oh, how is your headache? What's the number? How many days? A week, how many hours for each headache, how did it respond to triptan? When they always say it helps. Why? Actually, it helps more with the experience of the pain rather than pain score. So because it helps with the psychological component of pain depression. Here also they looked at those anxiety, depression, sleep, but again they looked at 5 weeks from one dose. Actually, the protocol for depression, it's more standardized than our protocol for chronic pain, and it's frequent infusion. It's not, and at higher doses, actually. So this is not a protocol meant to target anxiety, depression, but I think this is a major component of patient with pain, chronic headaches. I just want to make a quick comment because it's interesting when you look at data. You can read it in the way you want to read it. Here, they analyze it as an intent of treat, which is
Mhm.
perfect. But I can read it in a different way. I can say at day 7, 50% of patients had great pain relief. At 5 weeks, 25% of the patient had good pain relief. If I made this statement, 50% of patients got great pain relief at 7 days, this is not bad, because we have, each patient is different. Each patient has different experience. So if you have a chance 1 out of 2, honestly, do you want to deny this to the patient? We need to practice patient-centered care. So you have a tool in your hand that can fix 1 out of those 2 patients. Would you offer it to both patients? I would. For the FDA to approve new migraine medications, they need 30% relief from every dose. And you don't give 1 triptan and you said, oh, I cured your migraine. No. So 50% relief on day 7, actually, it's not bad. What I learned from this is placebo is true, because 20% of the patient had pain relief in the first week, and actually 15% at week 5, 35 days. So actually, this confirmed what we see clinically, honestly, that we do it for a few days in a row, or we do it every 5 days, or every week, 2 to 3 times, depending on the condition. And you need to repeat it, definitely. My other point was magnesium. I was kind of surprised. I don't know if you guys use magnesium for acute pain, but I'm a headache specialist. That's why I always think I get deviated about headache. Actually, magnesium is for prevention. Magnesium is more for migraine prevention. And actually, this is one of the best evidence. It's level B. Especially with migraine with aura, because it blocks the cortical spreading depression that are responsible for aura. So I don't think it's magnesium. It definitely has acute. It has studied in acute migraine, but it does not have the same evidence like chronic migraine. Combining them with ketamine was really new to me. It didn't add much, but we use magnesium mainly orally for chronic migraine prevention. Sometimes IV, definitely part of the migraine cocktail for status migrainosus, yes. But it has more evidence for chronic migraine prevention.
Before we continue a little bit more on magnesium here, there's a comment, Gordon, you make a comment about some of your experience about, it sounds like ketamine infusions in Canada. If you're still listening, I would love to get a little bit more detail about what you're referring to. I didn't quite understand your comment. Said that it's a major issue in Canada, but partly because of how their medical system works. If you have a little bit more detail, I would love to hear more about that. If you can type that up and put that in there. I think the magnesium question, I don't use it much in acute pain. I know it's been talked about a lot in acute pain as one of the newer multimodal adjuncts. We have never really gotten into it, but the context of it being an NMDA interactive medication for patients who have acute on chronic pain, I think that's where this comes up in this situation. Gary and Ketan, let me start with Gary first. What context have you used magnesium in this for pain?
Just very rarely, like Sam says, he uses it more than me because he treats a lot more headache than I do. But for the chronic migraine patient, it seems to be beneficial. I would like to see like a study for these chronic neuropathic pains, obviously taking out the diabetic neuropathy type of patient and the 20-year back pain neuropathic, like an oral magnesium study with weekly ketamine for these episodic episodes and see how that does. I would like to see that treatment because numerous studies have shown, as Sam pointed out before, like at 7 days, 50% relief for 50% of the patients in a neuropathic pain state to get relief is pretty impressive in clinical practice. And as he stated before, like a one-time magnesium dose, I don't think it's going to do much for these chronic states, but for an everyday oral dose, which is still very cost effective, in addition to the weekly IV, I'd like to see how that played out in the future, if someone would study that. So researchers, there's an idea.
Ketan, how about you guys? Did you guys ever use magnesium much, or do you?
Not particularly. As a resident, sometimes I would just, we had a thoracic surgeon who, for whatever reason, during his thoracotomies, didn't use epidurals, for whatever reason. And oftentimes I would run ketamine and magnesium for postoperative pain control throughout those cases. So that's super anecdotal, not studied, things like that. But that's really the only experience that I had with it. From a chronic pain perspective, sometimes you'll get patients who are on a good amount of opioids, as we all do, and I sort of use magnesium as a way to stimulate gastric motility. In that sense, it's not really I don't know if it's helping with their pain as much, but if you do have patients who are on high dose opioids, that you can kind of use magnesium in a twofold. You can say it does help with NMDA antagonism. Whether that's going to help someone who's on a high dose of opiates, I'm not really sure, but it can help a little bit with the side effects of the medication. So those are really my only two uses of it. We never at U of M used it as an infusion or anything intra-op or post-op or anything like that.
So Dr. Prithanand Singh in Singapore says that they've converted patients to oral. I'm thinking he means oral ketamine for intractable zoster or cancer pain. And it looks like they do a calculation post-infusion. So I don't know if we have access to in the States, do we have access to an oral ketamine that's readily available, or is that still more of an international solution?
I'm not sure if he meant oral ketamine or oral magnesium.
Yeah, I'm not sure either.
No, we don't have. It's not accessible. But intranasal ketamine, yes. I have maybe a handful of patients, intractable cluster headache patient, that I prescribe them intranasal ketamine, very limited doses. It's really, really helpful. But it's very dangerous because it has high risk of drug use disorder.
Mm-hmm.
But back to magnesium, for Gary, when he said daily dose, actually ask any headache patient. This is pretty standard. Migraine patient, they have daily migraine. This is part of their life. Over-the-counter magnesium oxide is very cheap. Take it twice a day. It's a standard. We don't test magnesium level, but it's very well known that magnesium level is low in migraine. We don't test it because, just a 1 minute explanation here. It does not reflect the intracellular level or the brain level of magnesium, because magnesium is stored in the bone, So if you want to test it, you test the ionized fraction of the magnesium. This is very expensive. So we don't test it at all. We just give it empirically. And only in research, you do ionized level of magnesium or the magnesium level inside the RPCs. This will give you a good reflection of the magnesium level in the brain. And it's extremely helpful for migraine in general, especially migraine with aura. So again, if the daily dose, again, it's for headache patient, they get used to it. I didn't think about it to try it daily for patient with neuropathic pain. I'm not sure. Maybe I need to look back in the literature. Maybe someone done it years ago, but I'm not aware. It's a good point.
So as we wind this down, just for the purposes of this conversation on this paper, sounds like these guys have come up with a study design that's a useful design for other follow-up studies to kind of mimic and track patients. It looks like, Sam, you're indicating that we need to be looking at people's pain in a shorter time frame with repeat dosing, and not necessarily waiting 5 weeks between every dose, or allowing that washout period to go on for 5 weeks before the next medication, but that there is signs of hope here. And it does not necessarily, this study does not necessarily say that IV ketamine and IV magnesium are of no use, but rather that there's more detail that needs to be teased out of this. Am I summarizing that fairly well?
Perfect. The last comment, I don't want to sound like I'm a big advocate for ketamine. Usually we call it vitamin K, because there is current abuse of using IV ketamine. I'm not abused like abuse disorder. I mean financially. There is clinics here and there just for IV ketamine for wellness, to treat addiction. I don't think there is a sound literature supporting this. What I'm saying, it's a short term, doesn't mean that we're going to do it every week for good. We think, based on consensus, in the recent guidelines, maximum 5 to 10 infusions a year is reasonable for chronic recurrent pain disorders, but definitely not like IV hydration clinics or IV vitamin clinics that you just to go walk in and get an infusion and go home. We have to be cautious also.
And someone, Lucy Hostetter asked the question, is anyone looking at S-ketamine in chronic pain conditions? Or I guess acute or chronic. I haven't used this drug.
I don't have experience with that.
Anybody know anything about that? So that may be part of a future discussion if we find more literature on that.
It's difficult to get it clinically because it's not FDA approved for the indication. It's still difficult to get IV ketamine infusion for pain patients. Do you get this difficulty, Gary?
Yeah, I get it.
It gets denied and denied. And
we get denied all the time. Some of my patients that need it, they just end up paying cash, and we try to make it an affordable option because they're suffering so much because the insurances don't cover it the majority of the time. Every once in a while, we'll write letter after letter after letter, and they'll approve. But by that point, their episodic issue is done.
Yeah, that's why when the patient responded well, usually we try to get pre-authorization for the next one. Usually they give us like 6 months use, and we keep it in the chart till we need it again, because this is exactly a very clinical issue that when you need it, you have to wait for pre-authorization and then it's over. Yeah.
That's why you see these clinics opening up, because it's a potential financial windfall for them. They don't have to wait. The patients just come in. They're not doing it through the insurance. They're wellness clinics and ketamine in clinics for their pain, depression, and it does have use in depression too, but that's out of the scope of the practice of this show.
No, I mean, they help patients. I'm not saying anything. It's just you have to be careful not overusing it and generalizing it to everyone with depression or everyone with any pain disorder. It's always, we have to be very selective still. It's a potent drug. We use it off-label, so we have to be careful with our patient selection.
Personalized care.
Yeah, exactly.
So I'll just put up the article name again and the date for everybody. If you're interested in going and seeing this article, I think it was a good, like I said, I'm mostly fascinated by their study design. I thought that was a really well executed study design. I would have liked to see a larger population, although their power analysis does indicate that their results are meaningful. We could argue about the power analysis ad nauseum if we wanted to, but it's a good, well done study, I think, and provides some information about what maybe these drugs are not good for. Doesn't mean they're not good for anything at all. Just as we wrap up, I want to thank all of you guys for joining on a Sunday evening. Appreciate it. And just as a reminder, go to ASRA.com, find out all the information about upcoming webinars, upcoming virtual conferences. There's actually, in this time period of quiet, solitary reflection, there's actually quite a lot going on. And I think the organization is stepping up to the difficult times that we're dealing with, just so we can continue to be educated and learn from each other and get to interact so that we maintain our relationships. But always good to talk to all of you, and I really appreciate you joining.
Same here. Thank you. Bye.
Have a good week, guys.
Thank you. You guys have a good week. Bye.